Hey all, welcome to today's session. We are going to discuss about the menstrual disorders today in detail. So, our goal for the next 20 minutes will be first one, learn the practical classification pathophysiology so you can make a rapid diagnosis in the clinic. Second, know the stepwise investigation to order, and third will be able to how to manage the things common problems safely both in the OPD and when admission is required. So these are the things we are going to discuss today. Let's begin with the topic. We'll go for a quick introduction. Menstrual disorders are any abnormalities of frequency, regularity, duration, or amount of bleeding from the uterus. So that is what called as uh, menstrual disorders. These are the abnormalities in cycle, duration, or amount of the bleeding from the uterus. So they are extremely common. They affect the quality of life, work, school, attendance, and fertility. In a clinic, you will see three typical complaints like heavy bleeding, irregular bleeding, and painful periods. So, always start with the question, is the patient stable? If not, manage as an emergency. If stable, we then do a structured history examination and targeted investigations. So, throughout this talk, I'll give you the things needed to know the conditions and exact investigations and orders, so you can note it down. And one important thing is always exclude pregnancy first in any abnormal bleeding. Okay, that is the one key point here. So, talking about the menstrual disorders, the classification. So, there are different types of menstrual disorders. So, amenorrhea, oligomenorrhea, polymenorrhea, menorrhagia, metrorrhagia, dysmenorrhea. So, we can classify these menstrual problems by what is abnormal. Amenorrhea is the absence of menses. Primary is like no absence of menstruation. So, no menarche by age 15 to 60 with secondary sexual characteristics absent or present. That is the primary. Secondary is no menses for if there is no menses for more than 3 cycles or more than 6 months in prior regular menses. So these are the absence of menstruation, amenorrhea. Second, oligomenorrhea, cycles which is greater than 35 days, that is infrequent cycles. Polymenorrhea, cycles which is less than 21 days, that is frequent polymenorrhea. Menorrhagia, heavy menstrual bleeding, traditionally greater than 80 ml per cycle or greater like more than 7 days, practically when bleeding causes anemia or impacts life. That is menorrhagia, that heavy bleeding. Metrorrhagia, it is the irregular bleeding between the periods. Dysmenorrhea is the painful menstruations, like it have two types, primary and secondary. Primary is the functional, prostaglandin driven, and secondary is like pathologically, maybe because of the endometriosis, fibroids, or adenomyosis, and PID and all. So this is the dysmenorrhea. So we'll use this as a framework to evaluate every patient who comes with a menstrual disorder. So when you hear abnormal bleeding, think of a of these conditions. So it can be any of these condition, maybe structural vices or maybe without the non-structural causes. So we'll talk about one by one now. Amenorrhea. Talking about amenorrhea, it can be primary and secondary. Amenorrhea starts always by asking about the pregnancy. After pregnancy is excluded, think of the other levels. One is uterine, outflow tract. Example, Asherman syndrome. So, intrauterine adhesions after curettage, Mullerian anomalies. So, these usually have a pelvic examination or history prior D&C, postpartum curettage and all. Second thing is ovarian. Go for PCOS, oligo or amenorrhea with hyperandrogenism, primary ovarian insufficiency. Consider FSH elevated in primary ovarian insufficiency. So that is the second, ovarian. Pituitary. Pituitary maybe because amenorrhea can be because of the, so these are the causes I'm talking, maybe etiology. From the pituitary, you can maybe hyperprolactinemia, galactorrhea, visual symptoms if adenoma. Fourth is hypothalamic, maybe due to stress, extreme weight loss, excessive exercise, low FSH and LH. Fifth is systemic, thyroid disease, chorionic illness, or significant weight loss. So these are the things you can maybe will be the causes of the amenorrhea. So what all investigations you can do stepwise? If we are saying immediate thing, go for urine beta HCG always. Second, basic lab test like CBC, look for anemia, thyroid stimulating hormone, prolactin, FSH, LH if a suspicion of ovarian failure. Serum testosterone can be done if virilization, cortisol if suspected adrenal cause. So that is a basic lab test you can do. Imaging techniques, go for pelvic ultrasound to identify uterus and ovaries, and Asherman's MRI, Asherman's and MRI pituitary if prolactin is very high or visual symptoms. So this is the investigations you can do in amenorrhea. OPD management if pregnancy is negative and mild hypothalamic PCOS features, lifestyle, weight loss, and start cycle regulation can be done. If hyperprolactinemia, treat with dopamine agonists like caprolactone 0.5 mg once or twice weekly, and check local protocol, and or you can also advise bromocriptine 2.5 mg BID, arrange the neurosurgical or endocrine follow-up if adenoma. And third is for Asherman's, you can refer for hysteroscopic adhesiolysis. Consider estrogen therapy to aid any endometrial regeneration. So that is the things you can do in OPD. And IPD management, if the patient has severe hypovolemia or severe endocrine crisis, admit the patient. For very high prolactin with the mass effect, coordinate with urgent endocrine review. For surgical causes needing operative correction, for example severe adhesions or planned operation. So this is the things you have to be keep in mind when you're treating the amenorrhea condition. And always consider an pregnancy test before any blood test, so it guides everything. So that is all about amenorrhea. Moving on to the oligomenorrhea and polymenorrhea. Oligomenorrhea and polymenorrhea. So, oligomenorrhea is the infrequent cycle which is most commonly due to anovulation, and the very common cause is PCOS. So, features of PCOS are irregular cycles, hirsutism or acne, obesity, ultrasound showing polycystic ovaries, and biochemical signs elevated like LH FSH ratio in some patients, and maybe due to the insulin resistance. Polymenorrhea has the frequent cycles, often reflects short follicular phases or bleeding disorders, and can be seen in the adolescents with anovulatory cycles or in perimenopausal women with irregular ovulation. So that is what about oligomenorrhea and polymenorrhea. And what are the investigations approach you can do is the pregnancy test. Then go for TSH, prolactin, serum androgens, fasting glucose, HbA1c, pelvic ultrasound also can be done. OPD management, how you can do PCOS. For PCOS, you can do lifestyle first, weight loss, improve cycles. Medically, you can go for combined OCP for cycle regulation and contraception. Consider metformin 500 mg BID increasing to 1500 to 2000 mg per day. And if in case of insulin resistance, if only after confirming the condition is due to because of PCOS, only then go for metformin. Okay, if fertility decide, ovulation induction can be done. So that can be done in the OPD management of oligomenorrhea and all. And polymenorrhea due to anovulation and the cyclic progestin, norethicitrone 5 mg TDS for 10 to 14 days, or COC to regulate cycles. COC is combined oral contraceptives to regulate the cycles. So these things you can do to treat the condition in the OPD level. And in IPD management, it is rare. Admit if any severe complications like bleeding or hemodynamic instability, and manage the menorrhagia. And next the manage menorrhagia. Next comes the menorrhagia or and metrorrhagia. Menorrhagia and metrorrhagia, like for heavy irregular bleeding, we use the palm coin classification: structural versus non-structural. So PALM, PALM, structural. So PALM is the structural thing, that is if it is polyp, adenomyosis present, leiomyoma, that is fibroid, malignancy and hyperplasia, that is the PALM, structural. Coin, COEIN, coin, non-structural. Coagulopathy or ovulatory dysfunction, endometrial iatrogenic drugs, not yet classified. So these are the palm coin method classification. For heavy and irregular bleeding, you should be knowing whether it is because of palm coin. Fibroids often cause heavy prolonged bleeding, and palpation may show enlarged irregular uterus. Then there are other things are adenomyosis. Adenomyosis may cause heavy painful bleeding in multiparous older patients. Next comes the endometrial hyperplasia. So these are the things maybe causing the menorrhagia and metrorrhagia. Endometrial hyperplasia malignancy is the risk with the prolonged anovulation, obesity, postmenopausal bleeding and all. Coagulopathy, think when heavy menses since menarche, family history or easy bruising. So this is the clinical clues you can go when you see patients with menorrhagia and metrorrhagia. So investigations you can order always pregnancy test first, then go for CBC, HbMCV and iron studies if anemia is suspected. Coagulation screen if severe bleeding or suggestive history, platelet count, PT and all, and consider all these testings in adolescents also. And thyroid stimulating hormone TSH to exclude any thyroid disease, pelvic ultrasound transvaginal to identify fibroids, polyps or adenomyosis signs. Next you can go for endometrial sampling, uh, curettage and all if greater than 45. Risk factors for hyperplasia or persistent abnormal bleeding, then go for endometrial sampling. Then you can go for hysteroscopy for focal lesions or when ultrasound is inconclusive. So that is the investigations you can do. And how you can manage the condition in OPD and IPD. OPD management is stable patients can be done in the OPD. First line is symptomatic, go for symptoms. Then advise tranexamic acid 1 gram orally TID during heavy bleeding days. Alternately 500 mg TID for up to 3 to 5 days per cycle. And explain the side effects of the medications like nausea and contraindications also. So in case of active thromboembolism it is contraindicated, so rule out the conditions. And then you can also advise NSAIDs, mefenamic acid, 500 mg loading, then 250 mg Q6 to 8 hour, or ibuprofen 400 mg Q6 to 8 hour to reduce blood loss and help pain. Next, you can advise hormonal options like combined oral contraceptive COC, cyclic or continuous to reduce blood loss, or you can also advise progesterone therapy also. Next is for long term, if you're giving medical like long term management, you can go for Mirena, 11 or Gestrel IUS is highly effective to control the uh, conditions and often first line for structural non-structural causes if not desiring pregnancy. So it reduces bleeding and improves the anemia. So that is the things you can do, the management of condition in OPD. And IPD management for those who are unstable or very severe bleeding cases, you can stabilize the patient with IV fluids, O negative blood if severe, cross match. Transfusion should be done if symptomatic patients or a HB less than 7 gram per DL. So all the things you should be it should be individualized. Okay, so medical measures you can give is high dose tranexamic acid IV and high dose progestogens can be given, or IV conjugated estrogens is in selected acute situation to stabilize endometrium. In any other procedures if you want to do suction curettage DNC if required, uterine tamponade like balloon for ongoing bleeding, uterine artery embolization for fibroid bleeding, or a hysterectomy for refractive severe cases. So always involve gynecology urgently. So if for example if a young adolescent presents with very heavy bleeding, always think bleeding disorder and refer for hemostasis early. So that is what the menorrhagia and metrorrhagia part. Moving on to the dysmenorrhea. Dysmenorrhea is like due to primarily it is pain from uterine prostaglandin release, common in adolescents soon after menarche. Pelvic examination and imaging techniques are normal. Pain typically starts with menses and is crampy, low abdominal pain, may have nausea and diarrhea. Secondary dysmenorrhea is due to pelvic pathology, maybe because of endometriosis, adenomyosis, fibroids, PID, IUD related, or ectopic. Pain, often progressive, may start earlier in cycle associated with the dyspareunia, infertility, or abnormal bleeding. So, investigations is focused history. You have to ask for onset, duration, relationship, how the relationship with the menses and response to the NSAIDs and sexual history. Pelvic examination can be done if sexually active, and pelvic ultrasound if suspicion of any secondary cause. And how we can manage the condition? OPD management is the first line of treatment. You can advise NSAIDs, first line of analgesia, ibuprofen 400 mg every 6 to 8 hours, up to 2400 mg per day, or mefenamic acid 500 mg loading, then 250 mg q 6 to 8 hour. Start at onset of bleeding, or ideally 1 day before expected menses for predictable cycles. Then you can advise hormonal suppression if NSAID is inadequate. You can go for COC, combined oral contraceptives, or progestin, POP, mini pills. Then you can also advise lifestyle things, hot bags, exercise, and counseling can be done. Then the IPD management in severe cases, uncontrolled pain, not responding to any oral medications, give IV NSAIDs, opioids if needed, and investigate for secondary causes. For endometriosis refractory to medical therapy, consider laparoscopic excision. So start your NSAID early, take it regularly. That is the counseling part you have to tell to the patient. Start the NSAID early, take it regularly for 48 to 72 hours when pain start. If it doesn't help, come back and so we have to consider the hormonal options. That is the counseling part you have to give to the patient who is having dysmenorrhea. Moving on to the clinical evaluation. Clinical evaluation, you can, as I've mentioned, history taking, cycle detail, associated symptoms, systemic illness also have to be done. Examination of general examination, CBC and all, thyroid examination, breast examination, pelvic examination can be done, and all the investigations. Like CBC, thyroid profile, FSH, LH, UST, pelvis, endometrial biopsies needed. So these are the clinical evaluation you can do whenever patient comes with a menstrual disorder. And the managements, so as I have individually mentioned how we have to manage the condition. So amenorrhea, we can advise lifestyle modification, treat the underlying cause, and oral contraceptive pills for cycle regulations can be done. Oligomenorrhea and polymenorrhea, go for hormonal therapy, manage. It is mainly because of thyroid disease or PCOS most of the time, so you can go for hormonal therapy and manage the thyroid and PCOS. Menorrhagia, you can go for NSAIDs, tranexamic acid, combined OCPs. Dysmenorrhea, NSAIDs, antispasmodics, and reassurance can be done. So this is how you can manage the condition in the OPD level. Moving on to the IPD management, in case of severe menorrhagia, you can go for IV tranexamic acid, blood transfusion if HB is very low. In cases of secondary dysmenorrhea like endometriosis or fibroid condition, maybe surgical intervention is needed. Refractory cases, very severe cases is not able to handle it, then go for TNC, hysteroscopy, hysterectomy. These things should be done in a selected patients only. So these things you can do in the IPD management. So counseling is the key in OPD. Counseling, like, you should be able to counsel the patient properly, and also you have to advise them for the follow-up plan. So reassess in 4 to 6 weeks for HB and symptom response, and also after initiating any hormonal therapy. So follow-up is very required. When in IPD management, once stable, plan a long-term therapy like surgery or LNGIUS and all based on the cause, and document clearly and arrange the outpatient follow-up and engage the hematology if bleeding disorder is suspected. So this is the IPD management. Next is the scope and importance. Why does this important? Because menstrual disorders are not trivial. They cause iron deficiency, anemia, reduce school or work attendance, affect the fertility and relationship. So early recognition prevents the further complications. So we can able to treat the anemia, identify endometrial hyperplasia or cancer early, and diagnose the bleeding disorders in adolescents. So counseling is vital, and there are also many myths which exist. Combating misinformation increases the adherence. So in public health, treating anemia and offering effective contraceptive options reduce the morbidity. So counseling and patient education plays a very important role in the menstrual disorders. So let's conclude today's topic. Menstrual disorders are like a common OPD complaints. Always exclude pregnancy first. Use the classification palm coin, which I've mentioned, structural and non-structural part, to guide the investigation. Then investigation, go for beta HCG, CBC, and for iron studies, TSH, prolactin, pelvic ultrasound, and endometrial sampling and when indicated. And for OPD, most patients are managed OPD basis, so you can advise the management therapies there. In IPD, one for the only for the severe cases, admit the patient in IPD and give the necessary requirement, medical attention, and surgical options as needed. And always document the counseling and arrange the follow up whenever necessary. So if you remember one thing, if you want to remember one thing, have a stepwise evidence based approach. So first you have to rule out pregnancy, then you go for hemodynamic status, then go for basic lab test, then go for imaging techniques, and after that you will be knowing what is the reason, what are the causes, and what you have to treat. So you can give the targeted therapy. So that's it for today. I hope you got a clear idea of menstrual disorders. Thank you so much for patient listening. Have a nice day.